expanding horizons in worsening heart failure. There was a big trial called the Victoria trial. We will move on to that. So if the time permits, we will talk on the insights from the Victoria trial also at that of the session. See, the heart failure is a very big disease in Indian population because the geriatric population is very high in Indian population, and the people living with the diabetes are very high in number in India next to the China. The people living with hypertension are very high in number in India, and ischemic heart disease is a very common complication of the diabetes and hypertension in India. And all these diseases will lead to the heart failure if the people are living for a longer period. So in a single word, ischemic heart disease, diabetes, hypertension, old age are the important risk factors to get the heart failure. So if you see these numbers, there are about 8 to 10 million people in India getting the treatment for the heart failures. And the important thing in Indian population is we are getting the heart failure younger by about 10 years, maybe in some population maybe 20 to 30 years, younger to the Western population in getting the heart failure. The same thing also happens to your diabetes and hypertension because we are getting the young diabetics and young hypertensives in the society. And coronary artery disease is the most common etiology for the heart failure in India. And we should not forget the rheumatic heart disease, even though it is a very less in number nowadays, because of the good sanitation and because of the less and less sore throats in the children, we are getting the less number of the rheumatic heart disease right now. But that could be another important risk factor for the heart failures. And if you see the hospitalizations, 1 out of the 5 heart failure with reduced ejection fraction patients are re-hospitalized for heart failure at 1 year. So that means diagnosis of the heart failure means more and more hospitalizations. If you see the mortality, the 5-year mortality rate, 3 out of the every 5 Indian patients, the median survival time is just 3.1 years. So that means that if a diagnosis of the heart failure means the mortality is very, very closer and very, very earlier. And what is the cause of the death in our heart failure? So the cause of the death in heart failure is worsening of the heart failure itself. So worsening of the heart failure may be because of the failure of our brachytherapy, or maybe because of the poor compliance, or maybe because of the other risk factors which are causing worsening of the heart failure finally leads to the mortality. And as I told you that the heart failure is a progressive disease in the society. There are the baseline heart failure risk population are there. Those risk factors, high risk individuals are already told you, elderly population or the diabetics or hypertensive or ischemic heart disease or rheumatic heart diseases or alcoholic cardiomyopathy or post-viral myocarditis. So these are at high risk of getting the heart failure. And once they are in the heart failure, there is a residual heart failure risk because of the left ventricular hypertrophy, maybe because of the arrhythmias, or maybe because of the myocarditis, there is a residual heart failure risk. And then the worsening of the heart failure may be because of the several factors and finally leads to the advanced heart failure risk. And if you see the treatment aspect, and the initial treatment is mostly the high risk individuals and control of those risk factors. Suppose if the patient is a diabetic and control the diabetes very effectively. Suppose if the patient is an hypertensive, control the blood pressure very effectively in the same way, so control the other risk factors also. Once the diagnosis of the heart failure, then we will have the 4 pillars of the heart failure management. Failure or a residual heart failure risk, and definitely the only treatment that is required is the heart transplantation. Is the treatment of the choice. But as you all know that heart transplantation is not a small thing, and it's a very, very big problem, and a lot of the people they cannot afford or they are not fit to go for the heart failure population. See, the heart failure progression is punctuated by the repeated worsening of the heart failure event, each resulting in the reduced cardiac function. And if you see this slide, you know that the worsening of the heart failure event, and again the worsening of the heart failure event, and again the worsening of the heart failure event. So, heart failure is a progressive condition. So, this decompensation event every time requiring the IV diuretic therapy. You all agree with me when we are undergraduates or in the internists, the surgeons, in the casualty, lot of the people they come at the midnight with orthopnea, BND, etc. And if you give a 1 or 2 ampoules of the Lasix, and definitely they are asymptomatic, and the morning they want a discharge from the house. So again after 1 month or 2 months, again they get readmitted for these pulmonary edemas, and then with the diuretic therapy they do well, and later they discharge. But in the due course, so they may not respond to disease diuretic therapy, and finally they die prematurely because of the worsening of the heart failure. Worsening the heart failure events are associated with a poor prognosis. See, more than 1 in the 5 patients died within the 2 years of the first worsening heart failure event. So that is the reason I am saying that heart failure diagnosis is not good. Definitely these people will have a premature death. Each worsening heart failure event is associated with the high risk of recurrent hospitalization. If you see here in the Pinnacle study, 56% of the patients were hospitalized within 30 days of a worsening heart failure event. So within 30 days again they readmitted in the hospital for the heart failures. So on an average, patients are hospitalized twice in the 2 years following a worsening of the heart failure event. Risk of the severe death or hospitalization is highest in the early phase after the hospitalization. Risk of the severe death 46% higher in patients with the recent hospitalization versus the patients with no prior hospitalization. So as long as you are doing the outpatient management of the heart failure, they may live for the longer period. Once they admitted, and definitely that is an indication for the readmissions and mortality. Worsening heart failure events become more frequent as the heart failure progresses. As I told you that this is a progressive disease. The median gap between the first and the second hospitalization is 168 days, and whereas the median gap is just 29 days for each re-hospitalization between the 4th and the 5th hospitalization. So first hospitalization, second hospitalization, third hospitalization, or 4th and the 5th, the gap will reduce, and finally they die prematurely. So in the heart failure, the 2 things are very important: are the oxidative stress and the endothelial dysfunction. So stress and endothelial dysfunction, they reduce the bioavailability of the nitric oxide. You all agree with me that nitric oxide is very, very important for your vasodilatation. So the more the nitric oxide, the more the vasodilatation. The lesser the nitric oxide, more the vasoconstriction, leading to the heart failures or the failures. So the reactive oxygen species endothelial dysfunction that reduces the nitric oxide production. So there will be impaired vascular function contributing to the heart failure. So this is the very important, the nitric oxide and soluble glucanic cyclase and the cyclic glucanate monophosphate. The signaling pathways is not currently targeted by therapies for the heart failure. See, earlier I told you that the 4 pillars in the management of the heart failure: your RAS blockade, your naprolysin blockade, your sympathetic nervous activity blockade, and SGLT2 inhibitors. Now the Versuget. So this is the new drug entered into the market to improve the nitric oxide. That nitric oxide helps you in your vasodilatation and reduces the heart failures. So by directly stimulating this soluble glucanic cyclase, Versuget has the potential to improve the heart failure pathophysiology. So the more the nitric oxide, so this Versuget improves the nitric oxide and improves your cyclic glucanate monophosphate. It has a positive effect on the 3 things. One, on the heart. The second thing is the blood vessels, and the third thing is the kidneys. So in the heart, it reduces the inflammation. So inflammation will be reduced in the heart, and fibrosis will be reduced, and hypertrophy will be reduced. So you all agree with me that by reducing the inflammation in the myocardium, reducing the fibrosis, reducing the hypertrophy, you are keeping the heart functioning at a good level so that they will escape the heart failure. The same thing happens in the blood vessels also. So they reduces the vascular inflammation. You all agree with me that vascular inflammation is very, very important in diabetics, hypertensives, and other populations to cause premature deaths. So it reduces the vascular inflammation and improves the vasodilatation because it increases the nitric oxide. In the kidneys, they reduces the fibrosis and increases the renal blood flow. So obviously the more and more renal blood flow, so definitely there won't be any renal ischemia to cause CKD or the AKI. So the same thing here, same picturization. See, the current treatments for the heart failure reduce rejection fraction. See, you all know that heart failure is divided into the three groups according to your ejection fraction. Suppose if the ejection fraction is more than the 50%, so it is considered as the heart failure PEF. PEF means preserved ejection fraction. Suppose if the ejection fraction is less than the 40, you call it as the REF. REF means reduced ejection fraction. Suppose if the ejection fraction is between 40 and the 50, you consider as mid-range ejection fraction. So that's how the HF REF or HF PEF and mid-range ejection fraction is considered. So they were established based on the large randomized controlled trials focused on the patients with the most stable chronic heart failure with reduced ejection fraction. I think this is the best slide of our today's talk, comparing the paradigm heart failure study with the sacubitril and valsartan, that is the RNA molecule. And the second subject is the DAPA heart failure, where they use the dapagliflozin. And then the Emperor study, where they use the empagliflozin. And the fourth one is our today's molecule, Versicare, that is the Victoria trial. If you see the amount of the GFR for this inclusion criteria, in the sacubitril valsartan RNA group, the paradigm group, the GFR more than 30 were included. In the dapagliflozin group, more than the 30 were included. In the Emperor group, more than 20 were included, whereas in Victoria group, more than 15 ml per minute to the 1.73 square meters were included. So this clearly shows you that the group which were included in the Victoria are in the renal failure, the CKD, almost in the stage 4 and the 5 group. So very high risk individual, very advanced renal failure population were included in this group. And the recent heart failure decompensation, heart failure hospitalization within 6 months, or IV diuretic therapy used for the heart failure within the 3 months were included in the Victoria group. And NT-proBNP, that is a marker for your heart failure. Whenever you are in doubt, you can subject the, you can send the blood for the NT-proBNP for the rule out whether the patient is having the heart failure or not. So in the heart failure, presence of heart failure, this is elevated very high. The more the NT-proBNP, the more the severity of the heart failure. So in the Victoria trial, so there was NT-proBNP levels to the tune of about 2,816. That shows advanced heart failure population was also included in this group. And in the same way, diuretics usage. So if you see the diuretics is almost 20% of the people in the Victoria, they have used the diuretics. And the class 3 and the 4 breathlessness, nearly the 41%. And then the primary endpoint event rate is almost 37.8 in Victoria group. So these groups in the Victoria group, it clearly shows that they are very advanced disease with advanced renal failure and a history of the hospitalization with a history of the diuretic therapy. So the majority of Victoria patients received the multiple heart failure therapies before the randomization, and all randomized patients had a worsening heart failure event. This Versicare, when you introduce into the worsening of the heart failure population, that reduces the primary composite outcome of the first hospitalization or the CV death. And Versicare improved both the primary and the secondary outcomes in patients with chronic and worsening heart failure in the Victoria group. So the primary composite outcome, the total heart failure hospitalizations and the composite of all-cause mortality were significantly reduced with the Versicare versus the placebo. So you can start the Versicare for the primary for the patient at any time following a decompensation unit. So that your patient should have stopped the IV diuretics for at least 24 hours prior. That is the minimum indication to start it. So once the patient is the IV diuretic therapy, and better not to start the Versicare. So it has a favorable safety profile. Your adverse effects were numerically lower with the Versicare compared to the placebo. So the adverse effects are very, very low. No significant difference in the symptomatic hypotension with the syncope. So when you use the RNA molecule, as it contains the valsartan, the chances of having the hypoglycemia, hypotension is there. But this Versicare has is not causing any hypertension or a change in the blood pressure. In the same way, in the Victoria group, 90% of the patients achieved the target dose of 10 milligrams. The initial dose is the 2.5 mg onset dose, and then you can uptitrate the dose to the 10 milligrams in a span of 12 months. So higher the NT-proBNP, the higher the CV risk, and when you get added to the goal-directed medical therapy is well tolerated in patients with heart failure with reduced ejection fraction following a worsening heart failure. So the rate of the AEs, that is our adverse effects, are low, no significant difference in the hypertension or the syncope, and adherence is also good. So which patient you prescribe the Versuga? See, in hospital patient, prior to or at discharge, you can add the Versuga, and first follow-up appointment after the heart failure hospitalization, you can add this drug, or as an outpatient who has received the higher doses of the IV diuretics, but still the patient is symptomatic, so definitely you can use it. So in both the outpatients as well as the inpatients, you can add this Versuga for all our heart failure patients, not to have the worsening and early mortality. See, as I told you that the initial dose is the 2.5 milligrams at the onset, and you wait for the 2 weeks, that is 15 days, and then you can uptitrate the dose to the 5 milligrams, again wait for 15 days, and then in the next month you can go up to the 10 milligrams is the maximum tolerable dose. But don't start with the 10 milligrams as the initial dose of the therapy, slowly uptitrate the dose. What about the difference in the systolic blood pressure? Not much difference. And it may be suitable for the vulnerable patients due to its favorable safety profile. So patients at risk of the hypertension. Suppose if you want to use the ARNI at the risk of the hypertension, you should not use it because it contains ARB. Patient with the renal impairment, again we cannot use the ARNI because it contains the ARB, valsartan, so which is contraindicated in the CKD population of stage 4 and 5. And patients at risk of the hyperkalemia. Hyperkalemia is a very common in a chronic diabetic or hypertensive or CKD population. Again, in such individuals you can use it. So these three are very, very useful points in favor of the Versuga, where you can use in people who are at risk of hyperkalemia or the renal impairment or the hypertension. So, as I told you, there are 4 pillars in the management of the heart failure are the ARNI, beta blocker, mineraloreceptor antagonists like your aldactone or the SGLT inhibitors. Now we can add the 5th pillar is the Versuga in those people whom you can think that they are at higher risk of getting the hospitalization. So the Versuga is approved and recommended for patients with reduced ejection fraction following the worsening of the heart failure events. So the pharmacokinetics and the pharmacodynamics are the very, very good in here because the route of administration is only oral form, only 1 tablet a day with meal, and absorption is good, about 93%, and distribution mainly in the plasma. Metabolism through the major metabolic pathway is the glucuronidation. Elimination both in the urine and the feces, and the drug-drug interactions are very, very less, unlike your sacubitril and valsartan or the aspirin or the warfarin. So this is something about your Victoria trial and the usage of the Versuga in the management of the heart failure. So thank you very much for your patient hearing, and thanks Srikanth for giving me the opportunity.